Assalamualaikum and good morning to everyone. Honorable Hospital Director, respected teachers, colleagues, and dear participants. Today, on behalf of Department of Radiology and Imaging, I have the privilege of announcing our journal club presentation on a rare but clinically important condition titled Gallbladder Agenesis, a unique condition with common symptoms. The presentation will be delivered by our respected colleague, Dr. K Shorma, Associate Professor, Department of Radiology and Imaging. And the session will be chaired by Professor Dr. Masudur, Professor and Head, Department of Radiology and Imaging. With due respect, I would like to invite our Chairperson to kindly take the chair and conduct the rest of the session.
Honorable Director, sir. And said by the members. Today we are going to start a article, Gallbladder Agenesis. This will be focusing on common symptoms. This will be discussed by the Dr. K Shorma, and I will invite Dr. Sharma to discuss this article.
Honorable Chairperson sir, Honorable Director sir, my respected teachers, my dear colleague and beloved intern doctor, welcome to today's journal club presentation. Topic is Gallbladder Agenesis, a unique condition with common symptoms. With the permission of Chairperson, I am presenting my topics. Name of journal, Journal of Surgical Case Reports. Authors are Dyson Pheang Limbu, Ashish Kiran Shrestha, John E. College. Issue Volume 2025, Issue 9, September 2025, and published 20 September 2025. Abstract. Agenesis of the gallbladder is a rare abnormality with an incidence of 0.01 to 0.06% and affects more women than men. Many patients can present with abdominal pain, particularly biliary colic. A woman presented with symptoms and sign of biliary colic type pain. There was no history of cholecystectomy surgery. All her routine blood, including inflammatory markers, liver function test, and amylase, were within normal limit. A combination of trans-abdominal ultrasound, computerized tomography, MRCP, and HIDA scan concluded gallbladder agenesis without extrahepatic biliary atresia. Currently, she is being managed conservatively with analgesia and antispasmodics. Diagnosis begins by first excluding common pathologies. MRCP is the recommended investigations to diagnose gallbladder agenesis. Sphincter of OD dysfunction can cause biliary colic pain, and this is suggested to be the mechanism of pain seen with gallbladder agenesis. Antispasmodics medication and simple analgesia is effective for management of symptoms. Keywords: gallbladder agenesis, biliary colic, sphincter of OD dysfunction. Introduction. Agenesis of the gallbladder is when a person is born without a gallbladder. This is a rare abnormality with an incidence of 0.01 to 0.06%. Approximately 50% of patients can present with right upper quadrant abdominal pain, which can imitate biliary colic pain. However, many can remain asymptomatic. Women are affected more than men, with a likelihood ratio of 3:1, and typically affects patients in their 20 to 30 years of age. We present a rare case of gallbladder agenesis. A woman in her 50 years of age presented with a 3-day history of sudden onset, sharp, intermittent right upper quadrant pain with radiation to the right shoulder. The pain was exacerbated on eating, particularly fatty foods. On examination, she was tender on both superficial and deep palpation over the right upper quadrant with a positive Murphy's sign. She was afebrile and denied associated symptoms such as nausea and vomiting. She had presented with similar symptoms 5 days prior, which were managed with analgesia, and she was subsequently discharged. On admission, the patient's blood test showed normal inflammatory markers, liver function markers, and amylase. The patient underwent an abdominal ultrasound scan, which did not visualize gallbladder and gallstones. A computerized tomography abdomen pelvis scan was done, and the gallbladder could not be visualized. Further investigations, which include a MRCP and HIDA scan, confirmed a gallbladder bar with an intact biliary tree. The patient denied a history of a cholecystectomy. She was diagnosed with gallbladder agenesis. Table 1, patient blood test on admission: C-reactive protein, white cell count, amylase, total bilirubin, alkaline phosphatase, alkaline transaminase, albumin, all are within normal limits. This is the picture of ultrasound. Figure number 1 showing a smooth liver surface, and this is the hilum of liver but absence of gallbladder. And second picture, same, no gallbladder visualized. CT abdomen pelvis scan is coronal view showing the arrow point of where we expect the gallbladder here to be seen but cannot be visualized on this. Another coronal view CT abdomen, we expect the gallbladder here but cannot be visualized on the scan. This is the axial view of CT abdomen, arrow point to where they expect the gallbladder to be seen but cannot be visualized on the scan. Another axial view, we expect the gallbladder here but cannot be visualized. This is the figure of T2 weighted MRCP scan. The arrow point where expect the gallbladder to be seen but cannot be visualized. T2 weighted MRCP scan coronal view. The arrow point to where we expect the gallbladder but cannot be visualized. T2 weighted MRCP scan, another coronal view. This is the biliary tree but no gallbladder visualized. MR maximum intensity projection scan. The arrow marks point to the largely intact biliary tree. This is a biliary tree. The cystic duct cannot be seen branching from the common bile duct. This is the common bile. Another picture of MR maximum intensity projection scan. Here to be largely intact biliary tree. The cystic duct cannot be seen and no gallbladder. This is a figure of series of HIDA scan. The arrow point to likely a gallbladder bar but no gallbladder. The patient was managed with analgesia including morphine and oral hyoscine and butyrylbromide. After follow-up, 1 year later, she is being managed conservatively with simple analgesia and antispasmodics, which effectively control her pain. She has been referred to a tertiary center for endoscopic ultrasound and sphincteropody manometry to identify the cause behind her symptoms such as SOD dysfunction. This is the endoscopic ultrasound done. This is the endoscopic probe. This is the smooth liver area, but no gallbladder visualized. Another picture, this is the normal endoscopic ultrasound. This is the gallbladder, liver, portal vein, they are normal. But in this case, no gallbladder, no cystic duct visualized. Discussion. It is interesting to see how such a rare condition present with a typical biliary symptom. However, diagnosis begins by ruling out common pathologies. The most common causes of right upper quadrant pain are biliary colic, cholecystitis and choledocholithiasis. However, the patient's unremarkable inflammatory markers and liver function tests contradict the diagnosis. The absence of gallbladder and gallstones in the biliary tree was confirmed on ultrasound and MRCP, which ruled out biliary colic, cholecystitis and choledocholithiasis. Normal amylase level in addition to normal inflammatory markers indicate that acute pancreatitis was unlikely. Also, the CT scan did not show any sign of acute pancreatitis such as decreased pancreatic enhancement, peripancreatic fat standing or peripancreatic fluid collection. Gallbladder agenesis has been well documented in the form of a case report, although how it causes biliary colic-like pain is poorly understood. SOD dysfunction is a suggested mechanism. In SOD dysfunction, the flow of bile is interrupted by an acalculous obstruction. Gallbladder agenesis and cholecystectomy are both risk factors for SOD dysfunction. The pathologies of SOD dysfunction includes scarring from biliary stones or crystals, increased pressure from a thickened sphincter present of birth, or SOD smooth muscle spasm caused by neuronal or hormonal stimuli. This can cause backflow of bile, which increases the pressure in the SOD and causes biliary colic-like pain, akin to pathophysiology in post-cholecystectomy syndrome. Additionally, it has been reported that antispasmodics can alleviate the pain, which supports this theory. MRCP has been shown to be an effective investigation to diagnose gallbladder agenesis. However, due to the rarity of gallbladder agenesis, common pathologies must be first excluded, although there is literature advising laparoscopic exploration and invasive procedure is argued to be unnecessary due to the high sensitivity of MRCP. As SOD dysfunction is suggested to cause biliary colic pain, SOD manometry can be used to diagnose this. There are no guidelines for treating gallbladder agenesis. Pain can be managed with a combination of hyoscyalurobidyl bromide and simple analgesics. The use of nifedipine in patients with SOD has also been shown to be effective. A study by Khuro et al. Showed that taking nifedipine led to fewer pain episodes, fewer emergency visits, and used less pain medication compared to a placebo. If conservative management is ineffective, sphincterotomy can be considered depending on the Milwaukee classification of SOD type 1, type 2 and type 3. Type 1 SOD is characterized by both abnormal biochemical markers and dilated biliary or pancreatic duct seen as on imaging. Type 2 is characterized by abnormal biochemistry or imaging. Type 3 SOD has neither. Sphincterotomy is advised for type 1 and type 2 SOD. However, it is not advised in type 3 due to ineffectiveness and risk of post-sphincterotomy pancreatitis. In conclusion, gallbladder agenesis can present similarity to biliary colic, cholecystitis, and cholecystolithiasis. The pathophysiology behind this is suggested to be SOD dysfunction. MRCP is the diagnostic tool of choice. It is recommended to manage gallbladder agenesis conservatively. Symptom control with iosine butyl bromide, nifedipine, and simple analgesia is recommended. If conservative management is ineffective, then sphincterotomy can be considered depending on the Milwaukee classification of SOD. Conflict of interest statement, non-declared, funding, non-declared. These references are. Thanks for all.